step right up and prepare to peer into one of the most incredible, intricate journeys imaginable, the development of human life.
It really is amazing, isn't it?
It's a process unfolding, hidden away, a dance of cells and structures coming together with breathtaking precision. For centuries, it was largely a mystery.
Completely hidden from view.
But thanks to the marvels of modern technology, we now have this extraordinary power to look inside, to witness this intricate architecture being built. It's like having a secret high-definition window into the earliest, most vital stages of being.
It's profoundly complex and, every single detail matters.
And that ability to see inside is more than just fascinating. It's become absolutely critical for understanding well-being.
Oh, absolutely. By being able to observe the structures as they form, we can appreciate the expected blueprint, identify when development might be following a different path, and understand potential challenges that could impact that developing life. The technology isn't just amazing, it's a vital tool in ensuring the healthiest start possible.
Absolutely. And today we are taking a deep dive into one of the most significant applications of that technology, the fetal anomaly scan.
A really crucial scan.
It's a critical milestone in pregnancy, sometimes known as the second trimester anatomy scan, or TIFFA, that stands for Targeted Imaging for Fetal Anomalies.
Right, TIFFA. You hear that term quite a bit.
We've brought together a collection of sources to explore this crucial examination in detail. Our mission is to understand exactly what sonographers are looking for during this scan, how they systematically go about finding it, and what are the key structures, measurements, and potential findings they assess during this incredibly detailed look at developing life.
It really is a comprehensive check from head to toe. It builds upon earlier assessments, done in the first trimester, and provides this foundational understanding of the fetus's structural development, guiding potential next steps if needed.
And that systematic approach you mentioned is key.
It is. That systematic approach is what makes it so powerful in capturing a vast amount of information in a single examination.
Okay. And before we get into the specifics, we want to give a very special thank you to London Heartbeat's Z Academy UK for their educational support of this deep dive.
Yes, huge thanks to them.
They are dedicated to providing high-quality training in ultrasound and other medical fields. We really encourage you, our listener, to explore their over 150 popular courses. They cover a huge range of topics related to this and many other areas.
A really impressive range of courses.
And definitely subscribe to their social media channels on Facebook, Instagram, and YouTube. They share free, regular updates and insights, and it's a great way to not miss out on future amazing discussions and learning opportunities related to these fascinating fields.
Yeah, definitely check them out.
Check them out, London Heartbeat Z Academy.
Okay, let's unpack this scan itself. What exactly is the fetal anomaly scan, and when is it typically performed? Well, as you said, it goes by several names, but the core purpose is the same. It's a detailed ultrasound examination. And standard practice is to perform this scan during the second trimester, specifically between 18 and 22 weeks of gestation.
18 to 22 weeks? Why that specific window?
Well, there's a good reason for that timing. By this stage, the fetus has grown large enough, and its anatomy is developed to a level of detail where, most major structures can be clearly visualized and assessed.
Okay.
And at the same time, there's typically still plenty of amniotic fluid surrounding the fetus, which acts as a kind of natural window, allowing for clearer ultrasound images.
Right. So it's that sweet spot where development is advanced enough to see properly, and the imaging conditions are usually pretty optimal.
Exactly.
And what are the main goals? What are the sonographers and clinicians hoping to achieve by doing this scan?
Well, the objectives are quite comprehensive. The primary goal is a really detailed evaluation of fetal anatomy, a systematic check of all the visible structures. This leads directly to the next goal. Detecting structural anomalies, basically identifying if any part of the fetus hasn't developed in the expected way. It's about determining normalcy, confirming that structures appear typical for the gestational age. Critically, it's about identifying any severe abnormalities that might be present. And importantly, even if a definitive diagnosis isn't made right then, the scan aims to raise suspicion for potential issues that might need further, more specialized evaluation, like, additional scans, consultations with specialists, or other tests.
So it's a screening tool, essentially, looking for the blueprint and flagging anything that looks significantly different. I remember one of our sources mentioned a rule of 3 systematic scanning method, particularly for the head and face. Can you maybe elaborate on that idea of a systematic approach?
Yeah, that concept really highlights the absolute necessity of a methodical examination. To make sure every critical structure is evaluated consistently and accurately, sonographers follow a very specific systematic protocol. This isn't just about looking around randomly. It's about using standardized views and sort of sweeping through the anatomy in a specific predetermined order. For areas as complex as the head and face, having a systematic approach, whether it's that specific rule of three method or another protocol, ensures thoroughness and, crucially, reduces the chance of missing subtle or even obvious findings.
Consistency is key then.
Absolutely, consistency is key.
And the tool allowing us to do all this, of course, is ultrasound. We've touched on ultrasound before in other deep dives, maybe looking at breast imaging or detailed scans of a newborn's brain. Briefly, how does ultrasound work and what makes it so uniquely suited, so ideal for imaging during pregnancy?
Okay, so at its core, ultrasound uses high-frequency sound waves, way beyond the range of human hearing. A device called a transducer sends these sound waves into the body. When these sound waves hit different tissues or structures like bone, fluid, or soft tissue, they bounce back as echoes. The transducer then listens for these returning echoes, and the ultrasound machine processes the time it takes for the echo to return and the strength of that echo to build a real-time image on a screen.
So it's mapping things out with sound echoes.
Pretty much. And it's fundamentally different from technologies like mammography, which uses X-rays, or CT scans, which also use X-rays and are great for detailed cross-sections, or even MRI, which uses powerful magnetic fields and radio waves, and is often used for, say, highly detailed fetal brain development assessments later in pregnancy.
So it's sound waves, not radiation like X-rays or CT.
Yeah.
That immediately highlights one huge advantage for pregnancy, I'd imagine.
Exactly. That's probably one of the most significant advantages. Because it doesn't use ionizing radiation, ultrasound is considered safe for both the mother and the developing fetus. This allows for multiple scans throughout pregnancy if needed without that concern about radiation exposure.
Right, that's crucial.
But the advantages go beyond safety. Ultrasound is widely accessible in many healthcare settings, often much more so than MRI or CT. It's relatively low cost compared to those other modalities. Modern ultrasound machines are often portable, making them versatile. And generally, these scans don't require sedation for the patient, which is a big plus, especially in pregnancy. These are the very reasons why, as sources discussing even, say, neonatal cranial sonography point out, ultrasound is invaluable, easy access, low cost, portability, no radiation, no sedation. It translates directly to why it's the workhorse for prenatal imaging.
It makes perfect sense. Safe, accessible, real-time imaging. Okay, with that foundation set, let's start our anatomical tour, beginning right at the top with the fetal brain. Now, this area seems incredibly complex to assess with just sound waves.
Yeah.
How do sonographers even approach visualizing something so intricate?
You're right, it is complex, but sonographers rely on specific, standardized views. These are meticulously chosen because they reliably display the most critical structures for assessing normal development and identifying potential issues. In the second trimester, there are 3 primary standard views used for assessing the fetal brain. They are generally referred to as the thalamic view, the ventricular view, and the cerebellar view.
Thalamic, ventricular, cerebellar. And how comprehensive are these specific views? Can they really capture most potential brain issues?
Well, when these 3 views are acquired correctly as part of a thorough examination, they are remarkably effective. The information provided in the sources indicates that these 3 standard views alone can detect more than 95% of central nervous system disorders detectable by ultrasound at this stage.
Wow, over 95% just from those 3 windows. That is impressive.
It really is. And that statistic alone underscores just how vital it is for sonographers to master the precise planes and landmarks needed to obtain these views correctly.
Okay, so what are the key structures within the brain that are routinely checked in the anomaly scan protocol? What's on the checklist?
All right. During a routine scan, there's a systematic checklist of structures they assess. They take biometric measurements of the head, specifically the biparietal diameter, BPD, which is across the widest part of the skull,
Right.
and the head circumference, HCC. They evaluate the overall shape of the head and check the bone density of the skull. Inside the brain, they meticulously examine the falx, that midline structure separating the hemispheres, and the interhemispheric fissure.
That dividing line.
Exactly. It's crucial to visualize a smooth, straight fissure, as any irregularity can be a red flag, potentially suggesting abnormalities involving the corpus callosum or other key cerebral structures. They assess the size and appearance of the ventricles, visualize the cavum of the septi polliceae, often called the CSP,
CSP, got it.
and identify the thalamus. In the back of the brain, they look at the cerebellum and its central part, the vermis. They also check the cisterna magna, the fluid space behind the cerebellum, and measure the neutral fold thickness at the back of the neck. And increasingly, a median or sagittal view is attempted to specifically visualize the corpus callosum and the vermis in their midline profiles.
It's a really detailed list even before we break down the views. Let's go through those 3 standard views you mentioned and talk about exactly what is displayed and what sonographers are looking for in each, starting with the thalamic view.
Okay, the thalamic view. This is typically obtained as a transverse, or axial, a slice right through the fetal head. In this crucial plane, you see the structures located deep in the center of the brain. Prominently visible is the thalamus-hypothalamus complex. Located centrally within this complex is the third ventricle, which usually appears as a thin, slit-like midline structure. Just posterior to the thalamus, between the occipital lobes, is the ambient cistern. Now, while it's a CSF space, it actually appears echogenic on ultrasound, meaning it looks brighter.
Brighter, why is that?
Well, it's because of fine strands of meninges, the membranes, that traverse and support the structures in that region, so that echogenic appearance is normal.
Okay, so that bright appearance in the fluid space is normal due to those fine tissue strands. What else is captured in this thalamic view?
You also identify the insula, which appears as a short, brightly echogenic line. Branches of the middle cerebral artery are located within this area, contributing to its appearance. Located between the thalamus and the insula is an echogenic band representing the basal ganglia. More anteriorly, you can visualize the very front tips, the anterior horns of the lateral ventricles, and positioned between these horns is the cavum septipellucidi, the CSP we mentioned.
And this thalamic view is the standard view for taking those important head measurements like BPD and HC.
Precisely. This is the view utilized for obtaining those fundamental head biometry measurements. The biparietal diameter, BPD, the occipitofrontal diameter, OFD, and the head circumference, HEC. And as we highlighted earlier, it's also in this view that the appearance of the interhemispheric fissure, that structure dividing the brain into 2 halves, is carefully checked. Its presence and the observation that it's smooth and straight are key indicators. Any irregularity here is suspicious and warrants a closer look, potentially suggesting issues with the corpus callosum or other adjacent cerebral structures.
Okay, so the thalamic view is central for basic head size and symmetry, and for checking key midline structures like the thalamus, third ventricle, CSP, and assessing the interhemispheric fissure's integrity. Moving slightly higher now, what does the ventricular view show us?
The ventricular view is obtained by tilting or angling the transducer a little bit higher, slightly more towards the top of the head compared to the thalamic view. This view primarily brings into focus the bodies and, very importantly, the atria of the lateral ventricles.
The atria, okay.
The interhemispheric fissure is still visible in this plane as well. But the critical structure to evaluate in the ventricular view is the atrium of the occipital horn, which is the posterior most part of the lateral ventricle. This part of the ventricle is typically filled with the choroid plexus, which appears quite echogenic or bright on ultrasound.
That bright structure within the ventricle. And there are specific visual cues and measurements they use in this view to assess if the ventricles are the correct size.
Yes, absolutely. This is where you look for signs that the ventricles might be dilating, which could be an early indicator of potential issues. The sources provide key criteria for assessment here. First, the echogenic choroid plexus should normally fill more than 60% of the width of the atrium.
More than 60%.
Right. Second, and arguably more crucial, the space between the medial wall of the lateral ventricle, the wall closest to the midline, and the echogenic choroid plexus should measure less than 3 millimeters.
Less than 3 millimeters.
If this space is 3 millimeters or greater, it indicates that the ventricle is starting to enlarge relative to the choroid, which is definitely a red flag.
Those are very specific, detailed criteria. So the ventricular view focuses on assessing the size of the lateral ventricles using the relationship between the ventricle wall and the choroid plexus. Now, the third standard view is the cerebellar view. How is that obtained and what structures are visible there?
The cerebellar view brings the posterior fossa, which is the back part of the brain containing the cerebellum, into focus. It's typically obtained by rotating the transducer from the thalamic view.
Okay.
In this view, you clearly see the cerebellar hemispheres, located laterally, and in the midline, connecting the hemispheres, is the cerebellar vermis. The vermis usually appears slightly more echogenic and is narrower than the hemispheres themselves.
And this is where we see the cisterna magna as well, that fluid space.
Yes, exactly. The cisterna magna, which is a significant space filled with cerebrospinal fluid, is located posterior to the cerebellum and is visible between the cerebellum and the inner table of the occipital bone at the back of the skull. The size of the cerebellum itself and this fluid space are key components of this view.
You mentioned measuring the cerebellum. The transverse cerebellar diameter, or TCD, is an important measurement, isn't it?
Correct. The transverse cerebellar diameter, TCD, is measured as the maximal diameter from one edge of a cerebellar hemisphere to the other on an axial scan obtained in this cerebellar view. An interesting and clinically useful point highlighted in the source is that up to approximately 24 weeks of gestation, the measurement of the transverse cerebellar diameter in millimeters roughly corresponds to the gestational age in weeks.
Oh, that's handy. Millimeters equals weeks, roughly.
Yeah, it provides a quick check for appropriate growth. Another important note is that this measurement is not thought to be significantly altered even in cases of IUGR, or intrauterine growth restriction, which can affect other fetal measurements.
That's good to know. And the cisterna magna, the fluid space, that also has a specific normal size range.
It does. The cisterna magna is measured as the distance between the posterior aspect of the cerebellar vermis and the inner aspect of the occipital bone. This measurement is taken on a specific axial plane that includes the anterior end of the CSP and the midplane of the cerebellum. The established normal range for the cisterna magna in the second trimester is 2 to 10 millimeters.
2 to 10 millimeters. So a measurement outside that range is something to investigate further.
Definitely. If the cisterna magna appears significantly smaller than 2 millimeters, the source notes that obliteration of this space can suggest something like a Chiari II malformation, which is strongly associated with open spina bifida as brain tissue gets pulled down into this area.
Okay.
Conversely, if the cisterna magna is enlarged, measuring greater than 10 millimeter, this can be seen with conditions like megacisterna magna, where the space is enlarged but the vermis is intact, a Blake pouch cyst, vermian dysplasia, abnormal development of the vermis, Dandy-Walker syndrome, specific malformation involving the vermis and fourth ventricle, or even arachnoid cysts.
So deviations in this measurement prompt further evaluation to differentiate between those possibilities.
Exactly.
Speaking of cysts, the sources mentioned some findings in the fetal brain that, while they look like fluid collections, are often considered normal variants and not really a cause for major concern on their own. What are these usually normal variants?
Yeah, it's important for sonographers and clinicians to recognize these common variants so they aren't mistaken for more serious pathology. One example is choroid plexus cysts, often abbreviated as CPCs.
CPCs.
These are small cyst-like spaces seen within the choroid plexus, that bright structure inside the ventricles we talked about. They are thought to form simply due to the entrapment of cerebrospinal fluid within the normal infolding process of the neuroepithelium during development. They typically resolve later in pregnancy.
Okay, choroid plexus cysts are quite common then. What's another one?
Another variant is a Blake pouch cyst. This appears as a thin-walled cystic structure. It's located in the midline of the posterior fossa, typically situated behind the lower portion of the cerebellar vermis and the brainstem. Like CPCs, it's often just a transient finding.
And the third variant mentioned?
That would be the cavum veli interpositi, or CVI. This is described as a small collection of fluid, again located in the midline. Its specific location is below the splenium of the corpus callosum, which is the back part of that structure, behind the upper part of the brainstem, and situated above the region where the pineal gland is located.
So CPCs, Blake pouch cyst, CVI.
Right. And while these three are generally considered benign variants, their presence is always documented, and depending on other findings during the scan, they might occasionally warrant a follow-up scan, but typically on their own, they are not concerning.
It's reassuring to know there are findings that look like cysts, but are usually nothing to worry about. Let's go back to enlarged ventricles, though, as that sounds like a more significant finding. You mentioned the criteria for ventriculomegaly and hydrocephalus. Can you clarify again how the measurement is taken and the distinction between those two terms?
Absolutely. The measurement for the size of the lateral ventricle is specifically taken transversely across the atrium of the occipital horn, that posterior section we discussed in the ventricular view.
Right, the back part.
This is where the ventricle is typically widest and easiest to measure reliably.
And the definition of ventriculomegaly, what's the number?
Fetal ventriculomegaly is strictly defined by measurement. It is diagnosed when the transverse measurement across the atria of either the posterior or anterior horn of the lateral ventricles is greater than 10 millimeters at any point in the gestation.
Greater than 10 millimeter. Okay.
Another related criterion, as mentioned earlier, is a separation of more than 3 millimeter between the medial wall of the lateral ventricle and the echogenic choroid plexus filling the atrium. However, that 10 millimeter measurement of the atrium is the universally accepted definition of ventriculomegaly. It indicates the ventricles are larger than expected.
Okay, 10 millimeters of ventriculomegaly. So what then is the difference between ventriculomegaly and hydrocephalus? Is one more severe?
Yes, hydrocephalus is generally used for a more severe situation. Hydrocephalus refers to enlarged ventricles specifically associated with increased intracranial pressure.
Increased pressure.
Right. This increased pressure inside the skull typically leads to the head itself becoming enlarged. So while ventriculomegaly is just about ventricle size being above 10 millimeter, hydrocephalus implies a larger ventricle and the presence of increased pressure, often leading to head enlargement. The specific measurement criterion used in this context for hydrocephalus is a lateral ventricular diameter greater than 15 millimeter.
Greater than 15 millimeters, so a higher threshold.
Exactly. It indicates more significant enlargement. This measurement technique and the distinction are pretty consistent with how hydrocephalus is assessed even after birth. Sources on neonatal cranial ultrasound also describe measurement indices, like the Levine index, to quantify ventricular size in newborns, showing a continuity of assessment from fetus to infancy.
That connection to neonatal assessment is interesting. Makes sense they use similar approaches.
Mm-hmm.
Now, the sources categorize some serious brain conditions based on when errors occur during the very early stages of brain formation.
Yeah.
Can you explain what errors of dorsal induction are referring to?
Okay, so errors of dorsal induction relate to the very earliest steps in forming the central nervous system, specifically the spine and the posterior part of the brain. It begins with a structure called the notochord in the very early embryo.
Notochord, right.
The notochord sends signals that induce the layer above it, the dorsal ectoderm, to form the neural plate. This neural plate then curls up and closes to create the neural tube. The anterior part of this tube develops into the brain, and the rest becomes the spinal cord. Errors at this stage, often due to genetic factors or exposure to harmful substances, known as teratogens, mean this neural plate doesn't develop properly or the neural tube doesn't close completely. This whole process is called neurulation.
So these errors affect the formation and closure of that initial tube that becomes the brain and spinal cord. What specific conditions result from these types of errors?
Two major and very severe examples result from the failure of the rostral neuropore, that's the top opening of that neural tube to close. These are anencephaly and exencephaly.
Anencephaly and exencephaly.
In anencephaly, because the neural tube doesn't close at the top, the cranial vault, the bony covering of the skull, fails to develop properly, and much of the brain tissue is absent or exposed. Exencephaly is considered a precursor where the brain tissue is formed but remains exposed and unprotected outside the skull due to the cranial vault not closing.
Wow.
Anencephaly is so significant that it's listed in other sources as an anomaly that can often be detected very early, sometimes even in the first trimester ultrasound.
Those sound incredibly severe. What about cephalocyl and encephalocyl? Are they also related to this tube closure issue?
Yes, there are also structural defects involving the skull and brain related to closure problems. A cephalocyl is a general term describing the herniation, meaning bulging out of intracranial structures, through a defect, a gap, in the skull or the base of the skull.
Okay, a bulge through the skull.
Right. The distinction is what is contained within that bulge. If it only contains meninges, the membranes covering the brain and spinal cord and cerebrospinal fluid, CSF, it's called a cranial meningocele.
Just fluid and membrane.
But if it contains brain tissue itself, it's called an encephalocele. Like anencephaly, cephalocele is another anomaly mentioned in sources as being potentially detectable during the first trimester scan as well.
Okay, so dorsal induction errors primarily relate to the back part of the brain and spinal cord and the closure of the neural tube. What about errors of ventral induction? Where do those occur and what do they affect?
Right, so errors of ventral induction happen at the rostral or front end of the early embryo, specifically impacting the division and development of the forebrain.
The forebrain, okay.
These errors cause abnormalities in the prosencephalon, which is the primitive forebrain, the mesencephalon, midbrain, and the rhombencephalon, hindbrain. And because the structures of the face develop in close coordination with the forebrain, errors of ventral induction usually also impact facial development, leading to associated facial anomalies.
So brain and face development are linked there. And the main condition linked to these ventral induction errors.
The classic and most well-known condition resulting from errors of ventral induction is polyprosencephaly, often abbreviated as HPE.
HPE.
This is a complex malformation where the primitive forebrain, the prosencephalon, fails to completely separate into the two distinct right and left cerebral hemispheres. Instead of having two separate halves of the brain, there's some degree of fusion across the midline. The severity varies quite a bit, leading to a spectrum of conditions categorized into three main types. Allobar holoprosencephaly, which is the most severe form with basically a single undivided brain ventricle. Semilobar holoprosencephaly with partial separation. And lobar holoprosencephaly, the least severe form with mostly separated hemispheres, but still some midline fusion or communication.
A spectrum of severity, then.
Exactly. And holoprosencephaly is another anomaly mentioned in sources related to both first trimester ultrasound and neonatal cranial ultrasound, indicating its significance across different assessment periods.
It sounds like a really fundamental failure in dividing the brain into two halves. Let's move back to the posterior fossa again, the back lower part of the brain where the cerebellum sits. What are the key conditions sonographers are looking for in this area?
Yeah, the posterior fossa and the cerebellum are carefully evaluated because abnormalities here can significantly impact motor function and coordination later on. A significant condition they look for is Dandy Walker malformation, or DWM.
Dandy Walker, right.
The classic description involves a triad of sonographic findings. First, partial or complete agenesis of the cerebellar vermis, meaning that central connecting part of the cerebellum is either underdeveloped or completely absent.
Okay, missing vermis.
Second, there's cystic enlargement of the fourth ventricle, which is the fluid-filled space in that region. And third, there's often an elevated tentorium, the membrane that separates the cerebellum from the cerebrum above it. On ultrasound in a fetus, you often see an enlarged cisterna magna behind the cerebellum, sometimes with a distinctive keyhole deformity because of the abnormal connection to the enlarged fourth ventricle. DWM is consistently listed across various sources on congenital anomalies as a key finding to look for.
And you mentioned megacisterna magna earlier when we talked about the 210 mm range. How is that different from Dandy Walker? They both involve a large fluid space back there, don't they?
That's a crucial distinction, yes, as they can look somewhat similar at first glance. Megacisterna magna, or MCM, specifically refers to an enlargement of the cisterna magna, that fluid space behind the cerebellum measuring greater than 10 mm. But the key difference is that the cerebellar vermis is intact and normally formed.
Ah, the vermis is normal in MCM.
Exactly. Unlike Dandy Walker, there's no agenesis or significant dysplasia of the vermis. On imaging, MCM is typically just a clear, fluid-filled space behind a normal-appearing cerebellum. The source mentions that sometimes you can visualize the lateral walls of a persistent Blake pouch cyst contributing to the appearance, with echogenic subarachnoid fluid seen lateral to those walls. So while the space is big in both, the integrity of the vermis is the defining difference.
Got it. Large fluid space, but intact vermis in MCM versus absent or underdeveloped vermis in DWM. What about spina bifida? It's a relatively well-known neural tube defect. Is that assessed via cranial ultrasound signs?
Yes, spina bifida is a neural tube defect resulting from failure of the neural tube to close properly along the spine. While the primary defect is in the back, it has well-recognized associated findings within the fetal cranium.
Hogs in the head.
Right, due to the resulting abnormalities in cerebrospinal fluid dynamics and brain structure positioning. The source mentions spina bifida as an anomaly and refers to cranial signs associated with open spina bifida. These cranial signs, which include things like frontal bone scalloping, sometimes called a lemon sign, and a characteristic shape of the cerebellum often described as the banana sign because it indicates caudal displacement.
Lemon and banana signs, okay.
These are specifically looked for during the cranial assessment as they are strong indicators of an open spinal defect lower down. Although the specific visual details of these signs aren't provided in the text here, the scan protocol explicitly includes looking for these cranial markers because they are highly sensitive for identifying spina bifida.
Okay, so they're looking for indirect signs in the head that point to a potential problem lower down in the spine. That makes sense. Moving down from the head and the brain, let's turn our attention to the fetal face. What's the approach to evaluating the fetal face during the anomaly scan?
Okay, the assessment of the fetal face is another systematic process. It aims to evaluate key structures and identify potential facial dysmorphism or clefting, which can sometimes be associated with syndromes or other anomalies. When possible, sonographers try to get a good sagittal facial profile view.
That side view.
Exactly. The goal in this profile view is to clearly demonstrate the presence and evaluate the normal configuration of the nasal bone, the lips, the chin, and the forehead. It gives you that classic profile image.
So checking the overall shape and proportion from the side.
Precisely. Beyond the profile, axial or transverse, views of the orbits are critical. The purpose here is to verify that both globes the eyeballs are present, that they are of normal size, and importantly, that they are appropriately spaced apart. Measuring the distance between the orbits is a key part of this. Axial images are also taken through the maxilla and the alveolar ridge. That's the part of the upper jawbone where the teeth will eventually sit. This view is specifically used to determine if a cleft primary palate is present.
What about the rest of the palate, further back in the mouth?
Good question. The palate is the structure that separates the nasal cavity from the oral cavity. The source notes that visualizing the secondary palate, the hard and soft palate further back on standard 2D sonography, can be quite challenging.
Hard to see.
It can be. However, it explicitly mentions that specialized 3D sonographic views can be incredibly helpful and are often used to further assess the integrity of the palate if there is suspicion of a cleft.
So 3D ultrasound really adds another dimension there, quite literally, for visualizing complex structures like the palate. What does a normal fetal face typically look like on scan at this stage of the second trimester?
Well, the source provides an example showing what a normal 18-week fetal face profile view looks like. You can clearly see the well-formed nasal bone, the contour of the maxilla, upper jaw, and the mandible, lower jaw in the correct relationships. It provides that visual benchmark for comparison when assessing other fetuses.
Let's focus on the orbits for a moment. How are they best viewed, and what are the key measurements or assessments related to them?
The orbits containing the eyes are best assessed in either axial or coronal views. The assessment focuses on symmetry. The orbits should be symmetrical in size on both sides. Crucially, the distance between the orbits is measured. Sonographers measure both the outer interorbital distance between the outer edges of the orbits, and the inner interorbital distance between the inner edges.
Inner and outer distances.
Right. An axial view in the source illustrates how these caliper placements are made for measurement. And as sources on orbit ultrasound highlight, identifying normal anatomy here is fundamental to then recognizing pathology. They describe techniques for assessing the anterior and posterior chambers of the eye and the retroocular region behind the eyeball, laying the groundwork for detecting issues later.
And abnormal spacing between the orbits has specific terminology, doesn't it?
It does. If the distance between the orbits is abnormally small, it's termed hypotelorism.
Hypotelorism too close.
And if the eyes are spaced abnormally wide apart, it's called hypertelorism.
Hypertelorism too far apart.
Exactly. These findings are significant because they can be associated with various syndromes or underlying brain anomalies, particularly those related to ventral induction errors like holoprosencephaly, where severe hypertelorism is often a feature.
Right, linked back to the brain development. What about potential issues within the eyeball itself, like the lens? Can that be seen?
Yes, the source mentions that conditions affecting the lens can sometimes be detected prenatally. Congenital cataracts, for example, which are opacities or clouding of the lens present from birth, can potentially be diagnosed on prenatal sonography.
How do they look?
They typically appear as a rounded echogenic or bright mass located in the anterior portion of the globe within the lens area. Potential causes listed for congenital cataracts include various genetic disorders, infections like torch infections, specific syndromes, and conditions like microphthalmia, which means abnormally small eyes.
Okay.
And the broader context of orbit ultrasound sources also lists other potential pathologies that can be visualized in the eye area, such as choroidal melanoma, demonstrating the range of structures and potential findings evaluated in that region.
So even the lens can be visualized and assessed. Let's move to the nasal bone, which seems to be a particularly important marker, especially for certain conditions. What are they looking for when assessing the nasal bone?
The nasal bone assessment is performed on that mid-sagittal view of the face we discussed earlier, the profile view. In a typical normal fetus, you would ideally see 3 distinct echogenic lines representing the tip of the nasal bone, the skin over it, and maybe the cartilage structure. The source notes that historically, precisely defining hypoplasia, meaning an underdeveloped or short nasal bone, using ultrasound measurements was challenging, leading to different criteria over time. Current approaches often rely on measurement-based criteria, such as comparing the nasal bone length to the biparietal diameter using a gestational age-adjusted length, or applying a single-length cutoff, like, say, 0.25 centimeters below which it's considered short.
And there's a specific ratio involving the soft tissue thickness in front of the nose as well, isn't there? I think I saw that mentioned.
Yes, that's right. There's a ratio that compares the prenasal thickness, PT, the measurement of the soft tissue between the skin surface and the nasal bone, to the nasal bone length, NBL.
PT to NBL ratio.
Right. The source provides a normal range for nasal bone length in the second trimester, typically between 0.35 and 0.8 centimeters, depending on gestational age. It highlights that a PT-NBL ratio greater than 0.8 is associated with chromosomal abnormalities.
Greater than 0.8 is the flag.
Correct. While the raw formula notation for the studied relationship is quite technical,
Yeah, I saw that equation.
the takeaway for the sonographer is that there's a specific relationship between these two measurements, and if that ratio exceeds a certain threshold, it significantly increases the suspicion for underlying genetic conditions.
So it's a calculated risk indicator based on those specific measurements. And the most discussed finding related to the nasal bone, the big one.
Without question, the most significant finding related to the nasal bone in the second trimester scan is its absence or marked hypoplasia, meaning it's very short.
Absent or very short.
The source strongly emphasizes that the absence of a visible nasal bone on second trimester sonography, or significantly abnormally short nasal bone measurements when considered alongside other markers, substantially increases the detection rate for aneuploidy, most notably trisomy 21 or Down syndrome. It's considered one of the key soft markers for this condition.
That makes the nasal bone a really critical structure to assess carefully then. Let's revisit the lip and palate briefly. What specifically are they checking for there again?
As discussed, an upper lip defect, most commonly a cleft lip, is a key finding. It can be visualized during the scan, often best appreciated using angled coronal scanning views of the face.
How does it look?
On the ultrasound image, it appears as a vertical hypoechoic area, basically a darker line or gap extending through the fetal upper lip. Regarding the palate, while the secondary palate is hard to see on 2D, the primary palate, the front part, can be examined in the transverse or axial plane. And as noted, if any suspicion arises, 3D ultrasound is a valuable tool to further evaluate the palate's integrity.
And there was a mention of fetal swallowing as a functional check.
Yes, the source notes that it's considered good clinical practice for the sonographer to observe and comment on fetal swallowing activity in real time during the scan. Seeing the fetus swallow amniotic fluid is a reassuring sign that the swallowing mechanism is functioning and that the upper digestive tract, like the esophagus, is likely patent, meaning it's open and connected properly.
That's a neat functional check alongside the structural assessment. Finally, for the head and face region, the neutral fold thickness. We often hear about neutral translucency in the first trimester. How is the neutral fold assessed in the second trimester scan? Is it different?
It is slightly different. In the second trimester, it's the neutral fold thickness that is measured, not the translucency. This measurement is taken in a specific plane, the suboccipital brachmatic plane, which is an axial slice through the back of the head, essentially at the level of the cerebellum and cisterna magna.
Okay, specific plane at the back.
Right. The measurement itself is taken in the midline, from the outer edge of the fetal occipital bone at the back of the skull to the outer edge of the overlying skin. It's a caliper-to-caliper measurement of that soft tissue thickness right at the back of the neck.
And what is considered an abnormal measurement in the second trimester, and what's its significance?
For the second trimester scan, performed between 15 and 22 weeks, a neutral fold thickness measurement of 6 millimeters or greater is considered increased.
6 millimeters or more?
Exactly. Like an absent or short nasal bone, an increased neutral fold thickness in the second trimester is associated with an increased risk of trisomy 21. So it's another important soft marker they are diligently checking for during this scan.
Right, that completes a very thorough look at the head and face, covering brain development, potential anomalies, key measurements, facial features, and those important soft markers for genetic conditions. Let's move down the fetus now to the thorax, the chest area. What are the key components and features assessed here?
Okay, when evaluating the fetal thorax, sonographers assess several basic but important features. They check the overall shape of the chest, noting that it should be regular and transition smoothly down into the abdomen. They also examine the ribs, ensuring they have normal curvature and checking for any deformities or fractures.
And the lungs within the chest cavity, what should they look like?
The lungs themselves should appear homogeneous on ultrasound, meaning they have a relatively uniform texture throughout, without large cysts or masses. A critical part of the lung assessment is checking for mediastinal shift.
Mediastinal shift, what's that?
That means looking to see if the heart and other midline structures within the chest are pushed significantly to one side or the other. A shift can indicate that there's a mass or an issue in one of the lungs or the chest cavity that is taking up space and displacing the normal structures.
Ah, so something's pushing the heart over.
Exactly. They also check for any obvious masses within the lung tissue itself.
And is the diaphragm, that muscle separating the chest from the abdomen, visible?
Yes, the diaphragm can often be visualized during the scan. It appears as a hypoechoic or relatively darker, dividing line, separating the contents of the thoracic cavity, the lungs and heart from the contents of the abdominal cavity below it, like the liver and stomach. The source includes an example showing a sagittal view, a side view, of a fetus at 13 weeks, illustrating the clear distinction and relative positions of the fetal liver below, the lungs above, and the diaphragm dividing them. Visualizing the diaphragm's integrity is crucial because a defect here, like a congenital diaphragmatic hernia, can allow abdominal organs to move up into the chest.
Right, that's a serious issue. So, checking the basic structure, contents, and the dividing line. The source mentions that if an echogenic lesion, a bright spot, is seen in the fetal thorax, there's a differential diagnosis. What did that mean exactly?
Okay, so that means if the sonographer identifies an area in the fetal chest that appears unusually bright or echogenic on the ultrasound image, that finding isn't automatically one specific problem.
It could be different things.
Exactly. Instead, it could represent several different underlying conditions. The source indicates that there's a differential diagnosis list for such findings, meaning a list of possibilities that an echogenic lesion could be. These could range from certain types of lung malformations, like a can we mentioned earlier, to other less common issues. Identifying such a lesion prompts further investigation and likely a more detailed scan to determine the specific cause from that list of possibilities.
But the source doesn't list those possibilities here.
No, unfortunately, the source material itself doesn't provide the list, but knowing that a differential exists is key. It means a bright spot isn't a definitive diagnosis in itself, but a signal for further investigation.
Okay, so it flags something that needs a closer look. Now let's move to what is arguably one of the most complex and critical organs assessed during the anomaly scan, the fetal heart.
The evaluation of the fetal heart is indeed a cornerstone of the anomaly scan, given the potential significance of cardiac defects if they're present. The source provides a concise checklist outlining the basic structures they are looking for within the heart chambers.
Well, what's on the list?
They check for the presence of 2 ventricles and 2 atria, the 4 main chambers of the heart, expecting them to appear roughly equal in size at this stage of pregnancy. They look for the foramen oval, which is a normal opening in the wall between the 2 atria in the fetal circulation, and observe that its flap is moving correctly into the left atrium.
Okay.
They check that the pulmonary veins, which carry oxygenated blood from the lungs, in postnatal life anyway, are entering the left atrium. They assess the regular motion of the mitral valve located between the left atrium and left ventricle, and the tricuspid valve between the right atrium and right ventricle.
Checking the valves are working.
Right. And finally, they examine the interventricular septum, the muscular wall separating the 2 ventricles, looking for continuity without any obvious gaps or holes.
That's the basic internal checklist. And the primary view for the basic cardiac screening is the 4-chamber view, correct?
Absolutely. The standard basic cardiac screening examination performed during the anomalous scan is interpreted primarily from the 4-chamber view of the fetal heart. This view provides a cross-section showing all 4 chambers nicely.
And what do they assess in that view?
In this view, sonographers assess several vital parameters. First is the fetal heart rate. A normal regular heart rate during the 2nd trimester typically falls between 120 and 160 beats per minute.
Okay, rate first. And they're checking the heart's position within the chest as well.
Yes. The location of the heart is critical. It should be primarily located in the left side of the fetal chest. To confirm normal positioning, the sonographer will typically check that the heart is on the same side as the fetal stomach, which should also be located on the left side if the fetal situs or overall organ arrangement is normal.
Checking stomach and heart are both on the left.
Right. The source includes a helpful dual-screen example illustrating this point, showing the fetal stomach clearly on the left side, confirming normal situs, and the heart also predominantly on the left.
Is size also evaluated?
Correct. The size of the heart relative to the chest is assessed. A normal heart should usually be no larger than about 1/3 of the total area of the fetal chest. They also check for the presence of a pericardial effusion, which is an abnormal accumulation of fluid around the heart within the pericardial sac, and which should typically be absent.
And the angle or orientation of the heart, how it's pointing.
Yes, the orientation of the heart within the chest is also assessed. Normally, the heart's axis, meaning the direction its apex or tip points, is deviated by approximately 45 degrees towards the left side of the fetus, with a normal range often considered to be 45 plus or minus 20 degrees. The source includes an image example demonstrating this normal position and axis within the chest cavity.
What if the heart isn't in that typical left-sided position? What if it's shifted over?
That would be noted as a variation in position. The source discusses dextroposition, which is when the heart is displaced towards the right side of the chest.
Dextroposition.
Right. This displacement is often caused by something occupying space in the left side of the chest, such as a mass within the lung, like a large congenital pulmonary airway malformation, what used to be called a CAM or CPAM, or potentially a congenital diaphragmatic hernia, allowing abdominal contents into the left chest.
So something pushes it over.
Often, yes. It's important to note that in dextroposition caused by an external mass, while the heart's body is shifted to the right, the apex, or the tip, typically still points towards the left. The source includes an image example clearly showing the heart shifted to the right due to a lung mass, but with its apex still pointing leftward.
Okay, so displacement is noted, and then they look for what might be pushing it there.
Yep.
The basic screen is the four-chamber view, but a more complete assessment requires looking beyond just the chambers, right? You need to see the great vessels coming out.
Absolutely. The apical four-chamber view is an essential starting point for evaluating the structure and relative sizes of the heart chambers, but a complete assessment of cardiac outflow tracts and the connections to the great vessels is necessary to detect many significant congenital heart defects.
So how do they see those?
Well, from the apical four-chamber view, a slight cephalad advancement of the transducer, meaning tilting it slightly towards the fetal head, brings you into an apical five-chamber view.
Five-chamber view.
This view is useful because it shows the left ventricle and its connection to the ascending aorta, allowing assessment of the continuity of the interventricular septum with the anterior wall of the aorta. It adds the aorta's exit to the picture.
Okay, so that shows the aorta coming off the left ventricle. And how do they visualize the pulmonary artery coming off the right ventricle?
Continuing that cephalad movement, or angling from the five-chamber view, should allow visualization of the main pulmonary artery as it arises from the right ventricle and bifurcates, or splits, into the right and left pulmonary arteries. This also shows its relationship to the aorta.
And there's another view specifically mentioned as crucial for evaluating the great vessels, the three-vessel and trachea view. Sounds important.
Yes, this view is considered extremely important, and the source strongly emphasizes that it should be visualized during the anomaly scan protocol. The three-vessel and trachea view, often called the 3VT view, provides a cross-section of the upper mediastinum, showing the three main vessels leaving the heart in their correct spatial relationship alongside the trachea.
Three vessels in the windpipe.
Exactly. This view allows evaluation of the main pulmonary artery as it connects to the ductus arteriosus, forming the pulmonary artery ductus confluens, the transverse aortic arch, and the superior vena cava, SVC.
And what critical information can you gather from seeing these three vessels together in this specific arrangement? What does it tell you?
This view provides several pieces of vital information. You can compare the relative sizes of the main pulmonary artery ductus confluens and the transverse aortic arch. They should be roughly similar in size, with the pulmonary artery typically being slightly larger in the fetus.
Okay, checking sizes.
You confirm that all three vessels are present and in their expected positions. And crucially, using color Doppler ultrasound, you can assess the direction of blood flow within these vessels.
Doppler shows the flow.
Right. The source describes the correct orientation in this view. The main pulmonary artery ductus arteriosus confluens is the largest vessel, the transverse aortic arch is next in size, and the SVC is the smallest, located posterior and to the right. Critically, it confirms that these two major vessels, the pulmonary artery and the aortic arch, are correctly positioned on the left side of the trachea.
So position relative to the trachea matters too.
Absolutely. Abnormal size relationships, absence of a vessel, or incorrect spatial arrangement are key indicators of significant cardiac or great vessel anomalies.
That sounds like a really powerful view then.
It is, and the use of color Doppler in the 3VT view to assess blood flow direction is a great example of how Doppler ultrasound is integrated into the anomaly scan. More broadly, Doppler ultrasound techniques in obstetrics are used to evaluate blood flow patterns in various fetal and maternal vessels, like the umbilical artery, the middle cerebral artery, MCA, in the brain, the uterine artery supplying the pregnancy, and the ductus venosus.
Huh?
Changes in these flow patterns can indicate serious conditions like intrauterine growth restriction, IUGR, fetal hypoxia, meaning low oxygen levels, or even maternal conditions like preeclampsia. So applying this Doppler technology specifically to the fetal heart and great vessels provides invaluable insights into the fetal circulation and helps identify abnormalities in blood flow dynamics.
And it makes perfect sense. You're not just seeing the structure, the anatomy, but also checking how the blood is actually flowing through it, the function.
Exactly. It adds a crucial functional layer to the anatomical assessment. It's also really important to remember that while the anomaly scan includes this basic cardiac screening, congenital cardiac defects are the most common type of birth defect, occurring in something like 2 to 6.5% of live births, as noted in some of the sources.
That common, wow.
Yeah, and many complex defects require a more specialized, detailed ultrasound of the heart called a fetal echocardiography. So if anything suspicious is seen during the basic anomaly scan cardiac views, referral for a dedicated fetal echo is often recommended because identifying these defects prenatally can significantly impact management and outcome for the baby.
So the anomaly scan is a critical screening tool for the heart, and if anything flags as potentially abnormal, a deeper dive with fetal echo is the next logical step. Okay, let's move further down the abdomen now to the fetal gastrointestinal system and the abdominal wall. What's assessed here?
Okay, the assessment of the fetal abdomen begins with establishing the correct cetus, meaning confirming the normal arrangement of the internal organs. The fetal stomach should be clearly identified and located in its expected position on the left side of the abdomen.
Stomach on the left, check.
Right. They also check that the vast majority of the fetal bowel is contained completely within the abdominal cavity and that the umbilical cord inserts cleanly into an intact abdominal wall right at the midline.
What about identifying any abnormal fluid collections within the abdomen, like
Yeah.
cysts or blockages?
Yes, the presence of any abnormal fluid collections within the bowel, such as isolated enteric cysts or segments of bowel that appear significantly dilated, should be documented. While some bowel dilatation can be transient, significant or persistent dilatation is a potential marker for obstruction somewhere downstream. The fetal gallbladder may also be seen in the right upper quadrant next to the liver, although the source notes that visualization of the gallbladder isn't considered a minimum required component of the basic anomaly scan. However, the presence of any other abnormal cystic structures visualized within the abdomen should definitely prompt referral for a more detailed evaluation.
And checking the umbilical cord insertion site is crucial for identifying certain defects, you said.
It is absolutely critical. The region where the umbilical cord inserts into the fetal abdomen must be carefully examined for any evidence of a ventral abdominal wall defect, such as an omphalocele or gastroschisis, where abdominal contents are actually located outside the body.
Right.
As an optional component of the scan, the number of vessels within the umbilical cord can also be counted using grayscale imaging. Normally, there are 3 vessels, 2 arteries, and 1 vein. A 2-vessel cord can sometimes be associated with other issues.
3 vessels is normal. Let's look at some specific findings related to the GI tract. What might it mean if the stomach bubble, which should be clearly visible on the left, isn't seen during the scan?
An absent stomach bubble is a finding that warrants investigation, definitely. Although it's important to note it can sometimes be transient due to just physiological emptying. Maybe the fetus hasn't swallowed recently.
Okay, could be temporary.
Could be. However, persistent absence or a consistently very small stomach bubble can indicate several potential issues. It might point to a lack of amniotic fluid for the fetus to swallow, such as with severe oligohydramnios or anhydramnios.
Not enough fluid to swallow.
Right. More importantly, it can suggest impaired fetal swallowing itself, which could be due to conditions like esophageal atresia, a blockage of the esophagus.
Nah, the swallowing tube is blocked.
Exactly. Or an obstructing mass in the mouth or pharynx, severe facial clefts that make swallowing difficult, or even a large congenital diaphragmatic hernia where abdominal contents have moved up and are compressing the esophagus or stomach.
You mentioned esophageal atresia. What are the typical sonographic signs of that condition specifically?
Okay, esophageal atresia, or EA, is a malformation where the esophagus ends in a blind pouch instead of connecting properly to the stomach. The main sonographic signs that raise suspicion include a persistently absent or very small stomach bubble, because fluid can't get down.
Right.
Polyhydramnios, that's an excessive amount of amniotic fluid because the fetus cannot swallow the amniotic fluid normally to regulate its volume.
Too much fluid builds up.
Correct. And sometimes you might visualize an esophageal pouch sign, which is a fluid collection seen in that blind-ending upper segment of the esophagus. Esophageal atresia is also listed in other sources as an anomaly that can sometimes be suspected even during the first trimester scan, although it's often clearer later.
What about the double bubble sign? That sounds quite descriptive. What does that look like and what could it indicate?
The double bubble sign is a classic ultrasound finding. It refers to seeing not just the normal gastric bubble, the stomach, but another distinct fluid-filled bubble right adjacent to it.
Two bubbles side by side.
Exactly. This second bubble represents a dilated duodenum, which is the first part of the small intestine, just after the stomach, and it indicates that it's obstructed. This sign strongly suggests duodenal atresia, a blockage in the duodenum. This condition is quite often associated with trisomy 21.
Okay, strong link to Down syndrome there.
It can be. However, the source notes that seeing a double bubble has other potential differential diagnoses as well, although duodenal atresia is the most common and significant cause. The other possibilities include things like a caudocal cyst, which is a cyst-like dilatation of the bile duct, or perhaps a duplication cyst within the bowel wall itself. But duodenal atresia is the prime suspect.
So the double bubble is a clear sign that needs further investigation to differentiate the cause, with duodenal atresia being a key concern. What about more general dilatation of the bowel further down? Is there a threshold for when that becomes suspicious for an obstruction?
Yes, simply seeing some fluid-filled bowel loops is normal. The fetus does swallow fluid, but their size is the key indicator of a potential obstruction lower down in the intestinal tract. The source provides specific size criteria for suspicion.
What are the numbers?
For the small bowel, a diameter greater than 7 millimeters is considered dilated and suggests a potential obstruction. For the large bowel, a diameter greater than 20 millimeters is considered suspicious for obstruction.
7 millimeters for small, 20 millimeters for large. Got it. The liver is also located in the upper abdomen. Is that routinely evaluated in detail?
The source notes that the fetal liver is typically clearly visualized in the upper abdomen, particularly as the pregnancy progresses into the second half of gestation. While a detailed assessment for liver pathology might not be part of the basic anomaly scan unless specifically indicated, its presence and general appearance are noted during the abdominal survey.
Okay. Let's turn to the abdominal wall defects now. You listed several types earlier. Can you elaborate on the most common ones, omphalocele and gastroschisis, and how they appear different on ultrasound?
Certainly. These are the two most common types of ventral abdominal wall defects. There are also less common and often more complex defects like bladder exstrophy, where the bladder is exposed, cloacal exstrophy, and ectopia cordis, where the heart is outside the chest.
Wow.
And even more severe and extensive defects involving significant portions of the body wall can occur, such as pentalogy of Cantrell, body stalk anomaly, and abdominoschisis as part of amniotic band syndrome. It's worth noting that several of these defects, gastroschisis, omphalocele, bladder exstrophy, and body stalk anomaly, are also explicitly listed in other sources as anomalies that can sometimes be identified during the first trimester scan, although the second trimester scan provides a much clearer view usually.
Let's focus on the two most common, omphalocele and gastroschisis. How do they look different on ultrasound, and what are the key features distinguishing them? It can be confusing.
The distinction is important, you're right. With an omphalocele, the source explains that it represents a failure of the abdominal contents to return fully into the abdomen from the umbilical cord during early development. Normally, the bowel herniates into the cord and then returns. So persistence of this midgut herniation bowel remaining in the cord beyond about 12 weeks of gestation, or the presence of content other than just intestine within the herniation sac, such as liver or stomach, are key indicators of a true abdominal wall defect, specifically an omphalocele.
And where is it located? And is it covered?
An omphalocele occurs right at the midline, at the base of the umbilical cord insertion. And critically, the herniated contents are typically covered by a sac made of peritoneum and amnion.
Okay, midline, covered by a sac, can contain liver. Now, gastroschisis, how does that differ?
Gastroschisis is a different type of defect altogether. It's described as a relatively small, usually less than 4 centimeters, full-thickness defect in the abdominal wall. It's typically located not at the umbilical cord insertion itself, but perumbilical, meaning next to it, most often just to the right of the umbilicus.
To the right, okay.
And the key ultrasound finding that distinguishes gastroschisis is the visualization of free-floating loops of bowel extruded outside the abdomen directly into the amniotic fluid. Unlike omphalocele, there is typically no covering sac over the herniated organs in gastroschisis. The bowel is just exposed to the amniotic fluid.
So omphalocele is midline, often larger, can contain other organs like liver, and importantly has a covering sac. Gastroschisis is usually smaller, off midline, often to the right, primarily involves uncovered bowel loops floating freely in the amniotic fluid. That's a clear distinction. What about bladder exstrophy? You mentioned that one too.
Right. Bladder exstrophy is another type of defect, though less common than omphalocele or gastroschisis. It's an infraumbilical, meaning below the umbilical cord abdominal wall defect, resulting from incomplete closure of the lower abdominal wall and the anterior wall of the bladder itself.
So the bladder is open on the outside.
Essentially, yes. On ultrasound, you might not see the bladder filling normally within the pelvis, and instead there's often a soft tissue mass visible on the lower abdominal wall that represents the exposed, everted bladder tissue.
That provides a clear picture of the range of abdominal wall issues. Okay, moving from the digestive system now to the fetal urogenital tract. That's the kidneys, bladder, and external genitalia. How are the kidneys assessed during the scan?
Okay, the assessment of the fetal kidneys is a standard and important part of the anomaly scan. Sonographers look for the presence and normal appearance of both kidneys. In the second trimester, they often appear as paired, relatively isoechoic structures, meaning they have a similar brightness or texture to the surrounding tissue located on either side of the fetal spine when viewed from the back in a transverse view. As the fetus matures, particularly into the third trimester, the corticomedullary differentiation, that's the visual distinction between the outer cortex and the inner medulla of the kidney, becomes more obvious. The source includes an image example from a transverse scan at 19 weeks, clearly showing the kidneys as these paired isoechoic structures flanking the spine with just a small amount of fluid visible within the renal pelvis, which is a normal finding.
Are the kidney sizes measured similar to how other organs like the femur are measured?
Yes, renal lengths are a standard measured parameter. The source actually provides a table listing normal fetal renal lengths ranging from 14 all the way to 42 weeks of gestation.
Oh, a reference chart.
Exactly. This highlights the importance of comparing the measured kidney length against these established norms for the specific gestational age to assess whether the kidneys are growing appropriately.
How is the renal pelvis, the collecting area within the kidney where urine gathers, assessed?
The renal pelvis is assessed by measuring its anterior-posterior AP diameter. This measurement is taken from the inner aspect of the front wall of the renal pelvis to the inner aspect of the back wall, basically the depth of the fluid collection there.
Okay, front to back measurement.
Right. In the second trimester, the upper limit of normal for the renal pelvis AP diameter is typically considered to be 4 to 5 millimeter. Measurements above this threshold, indicating dilatation of the renal pelvis, sometimes called pyelectasis, warrant further investigation for potential obstruction downstream in the urinary tract. They also look for evidence of renal cystic disease, where the kidney tissue itself is replaced by cysts.
And the fetal bladder, is that always visible? What are they looking for there?
The fetal bladder is typically visible on ultrasound after about 12 weeks of gestation as a fluid-filled structure in the fetal pelvis. Sonographers check for its presence and size. Concerning findings would include a persistently over-distended bladder, which can suggest an obstruction of the urinary tract lower down, like posterior urethral valves in a male fetus.
Bladder outlet obstruction.
Right. Or bilateral hydroureteronephrosis, which is dilatation of both ureters, the tubes from the kidneys to the bladder, and the kidneys above them, again strongly suggesting obstructive uropathy. And as other sources on congenital anomalies note, failure to visualize a kidney at all, renal genesis, or identifying a kidney that's completely replaced by multiple non-communicating cysts, multicystic dysplastic kidney or MCDK, are significant findings to look for.
So checking for the presence of both kidneys, their size, any signs of fluid backup in the pelvis or bladder, and ruling out cystic changes. Are there specific signs for a missing kidney? How do they spot that?
Yes, there's a helpful visual cue for renal agenesis, meaning absence of a kidney or perhaps a kidney located in an abnormal position, which is called ectopia. It's called the lying down adrenal sign.
Lying down adrenal.
Yeah. Normally, the adrenal gland sits sort of like a cap on top of the kidney. If a longitudinal scan is performed through the renal fossa, the expected location of the kidney, and the kidney is absent, the adrenal gland, which is no longer supported by the kidney underneath it, often appears flattened and elongated, essentially lying down in the space where the kidney should be. It's a strong, indirect sign that the kidney isn't there.
That's a very descriptive sign that helps identify when a kidney is missing or ectopic. What about conditions like polycystic kidney disease? Can that be seen?
Autosomal recessive polycystic kidney disease, or ARPKD, is a specific genetic condition affecting the kidneys. On ultrasound, evidence of ARPKD usually becomes apparent later in the second trimester, typically around 24 to 26 weeks, although it can sometimes be seen earlier.
How's it look?
An early presentation, as shown in an example from around 22 weeks in the source, often appears as bilaterally enlarged kidneys that are diffusely hyperechoic, meaning they are unusually bright throughout, with a loss of that normal corticomedullary differentiation we talked about. The kidneys look large and bright. The source even includes an algorithm outlining the systematic sonographic evaluation process for fetuses found to have hyperechogenic kidneys, indicating that this finding triggers a specific diagnostic pathway.
And what about structural anomalies where the kidneys might be fused together? Is that common?
That describes a horseshoe kidney, which is actually one of the more common fusion anomalies of the kidneys. The characteristic sonographic findings include an abnormal longitudinal axis of both kidneys. They don't lie parallel to the spine as expected, and usually a bridge of renal tissue connecting their lower poles, forming a kind of horseshoe shape. This bridge typically crosses anterior to the aorta.
Ah, fused at the bottom.
Right. The source describes imaging findings, noting that a coronal image might show that parenchymal bridge of tissue passing in front of the aorta, and an axial image would clearly show the fused isthmus connecting the lower poles and the abnormal anterior orientation of the kidneys.
Finally, for the urogenital tract, is fetal sex determination part of the anomaly scan? Do they check that?
Yes, determining fetal sex is a common and expected part of the second trimester anomaly scan. This is based on direct visualization of the external genitalia.
How do they tell?
In males, the presence of the penis and scrotum is identified. In females, the labia majora and minora are visualized, typically appearing as 2 or 4 parallel echogenic lines in the perineal view, sometimes referred to informally as the hamburger sign. This visualization allows for pretty reliable sex determination at this gestational age.
Okay, we've covered the abdomen and urogenital system in detail now. Wrapping up the anatomical survey, let's look at the fetal musculoskeletal system. That's the bones, limbs, hands, and feet. What are the key structures that are required to be assessed for the limbs?
Okay, the assessment of the fetal limbs is a standard part of the scan protocol, checking for presence, size, and normal formation. For the upper limbs, the protocol requires assessing both the upper arm bones, including measuring the humeral length, HL. They also check both the radius and ulna bones in the forearm on both sides.
Upper arm and forearm bones.
Right. Moving to the hands, they assess the fingers and thumbs, ensuring they are present and appear normal in number and structure. And they also assess for hand opening, confirming the fetus can move its fingers freely, which indicates neurological function as well.
And for the lower limbs, what's checked there?
For the lower limbs, they assess both femora, the thigh bones, including measuring the femoral length, FLL, which is a fundamental part of standard fetal biometry used to estimate fetal size and growth.
Femur length, FLL. That's the standard one.
It is. They also check both the tibia and fibula bones in the lower leg on both sides. Sonographers often use sagittal views of the lower leg and ankle to assess the orientation of the ankle and foot relative to the leg bones. This is a key part of screening for conditions like talipes, commonly known as clubfoot.
Checking for clubfoot.
Exactly. And finally, they assess both feet, checking their shape and position.
So measurement of key long bones like the femur and humerus is standard practice then?
Absolutely. Measuring the length of the femur, FL, is a core component of the anomaly scan and standard practice for evaluating fetal size and morphology. It contributes to the estimated fetal weight and provides important clues about skeletal development. While measuring every single long bone on both sides isn't necessarily required in the basic routine scan protocol for every fetus, an overall evaluation of the entire fetal skeleton is definitely performed.
What does that involve?
That overall evaluation includes checking that all the major tubular bones are present and that they appear symmetrical in length and shape on both sides of the body.
Beyond just checking for presence and length, are they looking at the appearance and shape of the bones themselves? Like, are they straight or bent?
Yes, that's a critical part of the assessment, particularly if there's any suspicion of a skeletal dysplasia, which are conditions affecting bone growth and cartilage development. Each major long bone is scanned carefully throughout its entire length.
What are they looking for specifically?
The sonographers are specifically looking for any abnormal bowing or angulation of the bone, or evidence of fractures, which might suggest brittle bone disease. They also make specific checks for the presence and normal appearance of the foot, looking again for talipes or clubfoot deformities, and visually count the number of fingers on each hand.
The source included tables of normal long bone lengths. How are those used in practice?
Those tables are essential reference tools. The source includes a table providing the normal range of lengths for the fetal extremity long bones, as well as biparietal diameter measurements at different menstrual ages, gestational weeks. During the scan, the measured lengths of bones like the femur and humerus are compared against these established normative charts.
So you check if the measurement fits the age.
Exactly. If a bone measurement falls significantly below the expected range for the gestational age, it raises suspicion for disproportionate shortening, which is a hallmark of many skeletal dysplasias, and it prompts further investigation.
And if there is limb shortening, different patterns of shortening have specific names, right? Like where the shortening occurs.
They do, and recognizing the pattern of shortening is very helpful in narrowing down the potential diagnosis among the many, many types of skeletal dysplasias. Rhizomelia refers to disproportionate shortening of the most proximal segment of the limb, so the humerus in the arm or the femur in the leg.
Rhizomelia, upper part short.
Mesomelia describes shortening of the middle segment, the radius and ulna in the forearm, or the tibia and fibula in the lower leg.
Mesomelia, middle part short.
Acromelia refers to shortening of the most distal segment, the hands and feet.
Acromelia and part short.
And micromelia is used when the entire limb appears significantly shortened. Identifying which segments is short really helps guide the diagnostic process.
That makes sense. The source even illustrates the appearance of femurs in various conditions. Can you describe some of those examples and how they appear different from a normal femur? It sounds like the shape can be quite telling.
Yes, the source provides some really good visual examples highlighting the spectrum of abnormal appearances of the femur that can be seen on ultrasound in different skeletal dysplasias. It starts by showing a normal femur and demonstrating how its length is measured correctly, excluding the cartilaginous epiphyses at the ends.
Okay, the normal baseline.
Then it shows examples of pathology. You might see an isolated hypoplastic left femur, where just one femur is significantly shorter than the other, but the lower leg bones and foot appear normal. In conditions like osteogenesis imperfecta type A, which is a milder form of brittle bone disease, you might see an isolated femoral fracture with sharp angulation, but otherwise relatively normal bone shape.
A break in the bone.
Right. Campomelic dysplasia is shown with mild shortening and a characteristic gentle, curved ventral bowing of the femur. It looks bent. Osteogenesis imperfecta type IA, a severe and often lethal form of brittle bone disease, is illustrated with a severely bowed femur exhibiting multiple discontinuities along its length, indicating multiple fractures.
Wow, multiple break.
Yeah. Hypophosphatasia, a disorder of mineralization, is shown with severe micromelia. The entire limb is very short, and the femur appears short and relatively broad, with a short diaphysis, the shaft, and a broad metaphysis, the area near the joint.
Short and broad.
And finally, the thanatophoric dysplasia, which is a common lethal skeletal dysplasia, is characterized by very short limbs, and the femurs often have a distinctive curved shape described as a telephone receiver shape.
Telephone receiver femur, that's memorable.
It is. Visualizing these specific shapes and features is absolutely key to differentiating these various conditions.
Those examples really underscore how detailed the skeletal assessment is, and how specific bone shapes can point towards very different diagnoses. We've now journeyed from the top of the head all the way down through the internal organs and the musculoskeletal system. The final structure evaluated during the anomaly scan is the placenta. What does the scan assess regarding the placenta?
Right. Evaluating the placenta is indeed an important final component of the second trimester anomaly scan. The primary assessment is determining placental localization. That means identifying exactly where the placenta is attached within the uterus.
Where is it located? Front, back, top?
Exactly. Noting if it's on the anterior wall, front, posterior wall, back, fundus top, or laterally. And importantly, its relationship to the cervix, the opening at the bottom of the uterus.
Are there specific placental locations or findings that are particularly important to identify during this scan? Why does the location relative to the cervix matter so much?
Yes, the relationship of the placenta to the cervix is critical. The source specifically mentions identifying a marginal placenta where the edge of the placenta comes close to the internal cervical os, the opening of the cervix, and a complete placenta previa where the placenta completely covers the internal cervical os.
Placenta previa, that sounds serious.
It can be. Placenta previa is a significant finding because it can lead to severe bleeding later in pregnancy or during delivery. The sources on placental ultrasound provide a broader context of other abnormalities detectable as well, including not only pruvia but also conditions like placenta accreta, where the placenta grows too deeply into the uterine wall,
Accreted.
placental infarction, areas of tissue death within the placenta, and various morphological abnormalities, meaning issues with its shape or structure. They also describe the normal appearance of the placenta on ultrasound, typically a relatively homogeneous texture with a clear hypoechoic, darker retroplacental space behind it, and link these visual findings to their clinical implications.
Are there other placental findings they might note?
Yes, the sources list a range of other findings that might be noted during a placental assessment, such as subchorionic cysts, which are just fluid collections beneath the chorion membrane, velamentous cord insertion, where the umbilical vessels aren't protected by Wharton's jelly near the placental insertion point, making them vulnerable, fascicular mole, which is an abnormal placental growth, calcification within the placenta, which is common later in pregnancy but can sometimes be seen earlier and be significant, chorioangioma, a benign tumor of the placenta, sexcenturiate placentae, which is like an extra lobe, circumvallate placenta, an abnormal shape where the membranes fold back on the fetal side, and venous lakes, which are basically pools of maternal blood within the placenta. Identifying any of these findings contributes to the overall assessment of placental health and function.
So it's definitely not just locating the placenta, but also checking its structure and looking for any features that could potentially impact the pregnancy.
Precisely. The health, structure, and position of the placenta are absolutely vital for nourishing and supporting the developing fetus, so a thorough assessment is included as a critical part of the fetal anomaly scan.
Well, we have really taken a deep dive today, navigating through the incredibly detailed assessment performed during the fetal anomaly scan. It's amazing, from the intricate structures of the brain and face, checking measurements and looking for subtle markers, down through the chest, assessing heart and lung position and structure, into the abdomen to check organ situs and bowel patency, then examining the kidneys and bladder for potential issues, assessing the musculoskeletal system for correct presence, size, and shape of bones, and finally evaluating the placenta for its location and health. It's genuinely incredible how much information can be gathered from this single ultrasound examination.
It really is. It offers such a comprehensive window into a developing life.
It truly is. This scan provides crucial information about the fetus's structural development, offering significant reassurance when everything appears to be following the expected pattern, and, critically, identifying potential challenges early on when they are present.
It's a powerful testament to the capabilities of modern ultrasound technology and, importantly, the high level of skill and systematic approach required by the sonographers and clinicians who perform and interpret these detailed examinations.
Absolutely. And we hope this deep dive has helped you, our listener, gain a much clearer understanding of what's involved in this important scan and why it's such a significant milestone in pregnancy. Whether you are personally anticipating this scan, are involved in healthcare, or simply have a profound curiosity about the wonders of human development and the technology that allows us to witness it.
Yeah,
This knowledge provides a deeper appreciation for the journey taking place.
it does. And thinking about the sheer amount of detail we've discussed today, from millimeter measurements of brain structures to recognizing specific shapes of tiny fetal bones and identifying subtle soft markers, it really makes you consider the extraordinary precision embedded in the biological blueprint of life itself.
The blueprint.
It also highlights how advanced our tools have become in deciphering that blueprint non-invasively, creating this ever-widening window into in utero development. Given how much we can already see and learn, it makes you wonder, what more is there still waiting to be discovered about these earliest stages of human life? What mysteries still lie within that visible world that we haven't quite figured out yet?
A fascinating thought to ponder indeed. What more will we see in the future? Thank you for joining us for this deep dive. We'll be back soon with another exploration of complex topics made clear and accessible here on the Deep Dive.